study program now officially. So if you guys we guarantee 100% success or your $3 back. What's going on, everybody? Welcome back to another episode of the Core Consults RX podcast. Today, we got a topic that's a little bit, how should we say, out of our wheelhouse, Cole?
Just a little bit
different. A little bit. Not as many medications for this, but a lot of background information and some other stuff we'll talk about.
Yeah, well, it's a common issue, and I don't know. I think the thoughts about it have changed since I was a kid. So we're talking food allergies.
Food allergies.
And obviously there's all sorts of different food allergies. And the kid with the peanut allergy when you were young was always like the one who was made fun of. But, that's not the case. It's a very unfortunate thing to have.
Yes. And also bullying's out now.
Bullying's out.
It's not cool anymore.
I'm not saying I bullied.
Yeah, I don't take you as a bullier.
I don't know that I have, but, there were people that bullied.
You witnessed bullying.
I witnessed it.
And yet you did nothing. So technically you're an accomplice.
So I'm a bully accomplice.
So there's that. That's out there forever now.
But it's interesting because not that old, but when I was a kid, there seems like there's more kids now who have food allergies than I was. And then older people say that there's more kids then that had food allergies than when they were kids and that sort of thing. And the prevalence is increasing. So whether it's just noticed more and tested for more, or whether it's a real thing, we'll kind of give maybe some of our opinions on that as we go throughout. But
kids are just getting soft.
That's one opinion.
That's my hypothesis, and I'm sticking with it.
So Mike was the bully who made fun of the kid.
No, I was a dork at that age.
Yeah.
I was 110 pounds all through high school.
We'll like Mike said, we'll take you through some of the background, some of the common allergens, what you can do to avoid them, and what to do in more emergent situations. Food allergies, it's an immunological issue. It's an adverse reaction mediated by foods. Any food protein can trigger an allergic response, but there's a specific few that seem to be the most common culprits, right? Milk, you hear about a lot, eggs, soy, fish and shellfish, trees, nuts, even wheat. Which I guess trees not necessarily, but tree nuts.
Nuts,
yes.
Yeah.
But
trees.
You can obviously be allergic to other things. You're just not going to be other like pine needles and things. You're just not going to be eating them.
Hopefully.
So tree nuts, wheats like celiacs and stuff.
Peanuts, you said.
Peanuts as one of the nuts. All those are pretty common food allergies, right?
Sesame starting to creep its way up the list.
All right. So sesame not just good for popping positive on a drug screen.
It's true. Poppy seeds?
Right. I think of a sesame bun, right? With
something
the poppy seeds on it. Something like that. I don't think that's a real thing.
We do very little research before we just make a blanket statement.
We do on our current topic. We just don't about random other stuff that we comment on.
If we had someone here that really could kind of back us up on these facts, it would be such a resource.
Yeah, we need a live fact checker. At the end, we need somebody to tell us all the things we got wrong throughout the episode.
You guys were 60% of the right. 60% of the time you were correct. Everything else was nonsense.
You said trees instead of tree nuts, and you said sesame instead of poppy seeds.
Remember in episode 3 that we ever did, you said 900 billion people died from the flu.
I think I said 100 million died from the 1918 flu pandemic.
Afterwards, we were like, wait, that seems like
too
many.
I think it was like a million.
That seems like too many.
Just a few too many.
Anyways.
Yeah.
All right. So, like you said, the food allergy, so it can be from a lot of different causes, but it's like, for example, with milk, it's lactose intolerance, which can be from a deficiency of lactase, the enzyme that breaks down lactose in milk, and it can also occur from foods that are just causing some sort of like a other effects that cause basically anaphylaxis. Now, there's also adverse reactions to food that happen from toxic type food. So things that have bacterial food poisoning or something like that, or food products that contain things like caffeine or something like that could pharmacologically cause issues. But there's sort of a lot of different comorbidities as well that can kind of be associated with these food allergies. A big one is atopic dermatitis. Now, as far as like its exact role in atopic dermatitis, it's kind of debated. But there's some studies that have showed that patients that have moderate or so chronic atopic dermatitis have 35 to 40% chance of having IgE-mediated food allergies as well. And so they do think they share some similarities there as far as the patho goes.
And that kind of goes to the ways that food allergies can present. So it can be more of a chronic disorder like Mike described with manifestations of atopic dermatitis or eosinophilic esophagitis. They can involve the GI tract, the respiratory tract, all that stuff. If it's more acute, you can have an anaphylactic reaction where it would be more respiratory tract, angioedema type thing where it's emergent and you're probably going to want to seek medical care. As far as which ones are more severe, investigations of near fatal or fatal anaphylactic reactions after food ingestion showed that the most common severe ones that could be fatal would be peanuts, tree nuts, not trees, and shellfish. Although milk has been increasingly reported, though we usually think of that as being one of the more mild ones, right? Because food allergies exist on a spectrum. It can make your stomach upset or it can kill you. And generally you would think of milk as being one that makes your stomach upset, but apparently people have had anaphylactic reactions to milk, which would be really unfortunate.
Right.
But yeah, the reaction, an example, like Mike said, an example is lactose intolerance. Some of them are toxic, that sort of thing, but that's just some background on food allergies.
All right, let's see. What do you want to go next?
I got some stats.
Hit me with the stats.
Hit you with some stats. So how common is it and who is it most common in? So as far as the genders go, it's more common in males when they're young, and it's more common in females when they're adults. The prevalence of food allergies, it's kind of hard to gauge. There's a lot of varying surveys out there. It's estimated to be up to 8% in infants and children and about 3.7% in adults, just in the general population. But it appears that over the course of the last few decades, it's generally increased by about 50% from where it was. So if, like I said, 3.7% of the adult population has a food allergy, maybe 5 to 6% does now. So the way you think about it, you would think that there's like 10 times as many people who have food allergies. Not necessarily, but the incidence is increasing. So it could just be because people are soft, like Mike says. It could also be the way that kids are exposed to different things when they're young. There's a lot more soap, a lot more hand sanitizer, maybe more avoidance of different viral infections and allergens in general. They think that all those things could play a role in why we're seeing an increased incidence of food allergies. And everybody's like, why is everybody allergic to gluten now? That might play a part as well. And then diets being different and that sort of thing. As far as which ones are most common, milk is probably the most common at about 2.5%. Eggs, next, peanuts, wheat, and soy, kind of in that order, as far as in children, what the most common food allergens are.
So as far as kind of some of the etiology at play, first, let's talk about the IgE, antibody-mediated responses. So that's a very widely recognized form of food allergy, and can kind of be the culprit behind those acute reactions that we can see. So basically, what happens is these patients are producing these IgE antibodies to specific epitopes, which would be like the areas of the protein that the antibodies bind to, and it binds to the epitopes of one or even more food allergens. And then these antibodies are going to have really high affinity to the IgE receptors on circulating basophils as well as like tissue mast cells, and that's going to be throughout the entire body, so skin, GI tract, respiratory tract. And then when you have this subsequent allergen exposure, you're going to get this, binding and cross-linking of those IgE antibodies on the cell surface, which is then going to cause the receptor activation, leading to basically the release of inflammatory mediators, as well as other cytokines and whatnot, and basically you get this allergic inflammation. And so because they're in the surrounding tissues, that's going to account for some of that vasodilation you can get, or the smooth muscle contraction, depending on where it is, the mucus secretion, and that's obviously what's going to be some of the more acute allergic reactions that patients will have. Now, like with cell-mediated responses, that can be seen more in like delayed or chronic type symptoms. So things like the food protein induced enterocolitis syndrome, or FPIES, I think is how you would abbreviate that, FPIES. And I'm not exactly sure how that's the cool way to say that.
I like FPIES.
I do too. I'm going to stick with it.
That also might be somebody who really doesn't like pies.
That is also a theory. But that's the gastrointestinal food allergy, and in that case, it seems to be mediated by T cells, as far as like their effect on the tumor necrosis factor alpha, TNF alpha, and so you'll see like basically patients, for example, with atopic dermatitis that flares up really bad when you have an ingestion of milk. They've seen that that's being associated with T cell activation and again, kind of activating some of those responses. Celiac disease is also an immune response to like things like the gluten, proteins, and grains, and so it's coming about it from like I said, cell-mediated response. And then as far as like risk factors go, because there's other sort of, I guess, allergens across different mucosal surfaces, but to kind of save you from some of the genetic type stuff, the just overall risk factors. So presence of asthma in a patient, especially if their asthma has been poorly controlled, that can be a risk factor for sort of having not only a food allergy, but a food-induced anaphylaxis as well. And then patients who have a previous episode, obviously, of anaphylaxis as a result of eating a certain food, they're going to definitely have a higher chance, especially if there's other foods they're not aware of that they're allergic to. And then patients that are basically not recognizing that the symptoms that they're having are indicative of anaphylaxis, because they're not going to maybe seek the treatment that they need right away. And then if the patients are not able to get access to epinephrine to treat their anaphylactic reaction, those are the ones that are going to have a higher chance of having a fatal experience, obviously, with these food-induced allergies or in anaphylaxis. So it's not something that's going to happen a lot, and we're getting better, like Cole said, of kind of identifying these patients and making sure they have things to manage an anaphylactic reaction to food, but unfortunately deaths and whatnot still are happening.
Yep, and there's some things in the pike coming that'll help with sensitization. We have one for peanuts, which we'll talk about at the end. But we talked about some of the manifestations and what it might look like. But as far as a physical exam goes, some symptoms that you might see of a patient who has food allergies. Obviously, if it's acute, it'll be pretty obvious. They might have angioedema or oropharyngeal pruritus. They might have itching, and they're going to have trouble breathing, wheezing, possibly stridor. If it's less acute, they might just have nausea and vomiting. Could be GI related, diarrhea, flushing, abdominal pain. Sometimes, with this or with other things, they'll describe that feeling of impending doom. But all symptoms that you could have with a food allergy. Taking their history is pretty important with this because it's not always super obvious what the offending agent is. So a thorough medical history is important. So maybe developing a complete list of all the foods you suspect, right? So just let's come up with a list. Talk about how the foods are prepared. Are they cooked? Are they raw? What spices are you using? Talk if the patient is aware of what food it is. Talk about what the minimum quantity that's required to kind of produce the symptoms. Are the symptoms reproducible? Or did they just happen once and they ate the same thing and it didn't happen again? Talk about family history, whether people they know in their family, direct or indirect, have other food allergies. Are there other eliciting factors like drugs like NSAIDs or other things like alcohol or exercise, that sort of thing? All that to kind of paint the picture to figure out what exactly it is and kind of narrow it down. You want a description of each reaction. Is it from ingestion? It can be skin contact. You can inhale something. What was the timing? How severe was it? How long did it last? How often does it happen? All those things are going to kind of paint a picture for what you think it is, and then what we can do to help mitigate and prevent that from happening in the future. Because it's not like we can give them, a statin and prevent their food allergies. A lot of it's just going to be lifestyle changes.
And also, too, this kind of goes without saying, but also assessing them for other comorbidities are often associated with this. So patients with atopic dermatitis or asthma or allergic rhinitis, that can also kind of lead you down one path or the other. Because if some of the symptoms, like for example, a lot of the GI symptoms or respiratory symptoms, they can kind of happen, especially if it's a more chronic allergy situation, not even necessarily like anaphylaxis. But a lot of like the GI complaints that people have, that can easily be something as simple as, I shouldn't say simple, but it could be just inflammatory bowel disease or irritable bowel syndrome. It could be, something along the lines of some sort of like a bacterial gastroenteritis or viral. Patients could have just really bad uncontrolled reflux. There's lots of things that can lead to these types of symptoms, so that differential diagnosis is going to be really important. Also, obviously, looking for things like celiac, or another thing would be looking for patients that maybe have some sort of underlying eating disorder too, like bulimia or something along those lines. Depending on how severe the GI symptoms are, especially if they have diarrhea associated with it, maybe looking for like C. diff. Lots of different things we could go into, but yeah, make sure that you're getting a full history.
Yeah, and there's some tests you can run as well. So you can do serum studies. You can test for IgE antibodies to certain foods. There's ways to do that can give you some information. You probably will instruct the patient to keep a diet diary, which is going to keep a record of all the foods they've eaten and whether there were associated symptoms and adverse effects and that sort of thing. It's what most people will think of in this situation and may try to do on their own is an elimination diet. That can be helpful for diagnostic and treatment purposes. Usually best if done under the direction of a physician, depending on how much they're going to eliminate. But it just involves taking away a specific food group that you think might be an offending agent for a certain period of time and seeing what happens. So usually it's over 7 to 14 days. But if you're trying to do it diagnostically, then maybe you say cut out milk for a week to 2 weeks and let's see what happens. Or if we've determined that milk is the offending agent, then we're going to try to eliminate that from the diet. So yeah, elimination diets are a common thing, and people will almost surely try that on their own if they have presumed that their maybe mild food allergy is related to food. There's also skin testing, so they can prick and puncture and see reactions, and these are kind of hit or miss. You'll see these done a lot, and these can be done to a very young age. Like I think a few months old, you can do skin prick tests. When doing them, it does the sensitivity depends on whether it was a negative test or a positive test. If it's a negative test, it's very likely that you are negative to that allergen. So I think there's about a 90% chance you're negative to that allergen. If it's a positive skin prick test, it's less sure, maybe about 50-50 as to whether you're actually allergic to that or if you just responded to this individual pinprick test. So I'm kind of hit or miss there, but if you don't respond, then that's a good thing. Probably not going to be the offending agent. There can also be medically supervised food challenges to confirm a food allergy. This sounds a little bit distressing. So it
sounds like a hot dog eating contest. Right. It's a food challenge.
It's a medically supervised hot dog eating contest.
Except 17-pound burger.
The person comes in and they're like, every time I drink milk, I have diarrhea. Okay, well, we need to confirm this. So we're going to have you drink
gallon of milk.
A whole gallon of milk.
We'll be in to check on you in a minute.
Don't do that. Yeah, but that's a thing that you can use, and it actually matters because some of this could be psychological. So you might have to have it blinded. You might have to have a placebo. Like there's double-blind placebo-controlled food challenges. They even have an acronym, DBPCFC.
That's harder to say than the actual phrase.
I know. It's fantastic. Yeah, but it's because maybe it's psychological because there's a lot of things going on serotonin wise in the gut. So maybe you just get an anxious stomach every time you drink milk, and it's not quite a clear allergy. So we want to just make sure before we have to cut milk out of your diet. I had to go milkless for a few months when I was a kid.
Did you?
Well, I was just having a lot of stomach problems, and the only thing which it's not like we got me checked out or anything. So the only thing my mom decided it was milk. So I had like the lactate milk and the lactate ice cream, which was really good. I actually liked it better than regular ice cream.
Really?
Shout out to Lactate.
Yeah, nice Lactate.
Now I probably wouldn't. It was very smooth, like that Breyers, like not real ice cream that you'll get that scoops really well, like the vanilla bean.
That was oddly specific.
This is what I remember from when I was a kid. It was great.
You're familiar with the 1995 Breyers line where they had the vanilla bean ice cream. That was good. Cole's a big ice cream connoisseur.
Well, we are, because as long as we're on this topic, ice cream brands range significantly as far as quality of ice cream. So what matters is how much air they inject into the ice cream. So when you look at a tub of ice cream, it can say ice cream, premium ice cream, or it could say frozen dairy dessert. If you're getting, that's the cheap stuff. If you're getting frozen dairy dessert,
sounds more bougie.
No, it's no good.
Okay.
It means that when they were mixing it together, they injected a lot of air in there, so a lot of it's fluff. So if you can even hold the gallon of frozen dairy dessert, then hold the gallon of like Bluebell, which is A+, right?
Right.
And you can tell the difference in the weight, because they've injected a bunch of air into it, so it fills up the container, but it's really light, and it's not even considered real ice cream.
That's
frozen
probably
dairy dessert.
with the low carb, like the Halo tops.
Oh, yeah.
Yeah.
I'm sure.
What's great is, like, I'm trying to just get some kind of in shape now that I'm in my 30s and not an athlete anymore. And so what my wife will do is she'll get the delicious ice cream for herself. And then, like, I'll just get, like, a Halo top where it's like, it's basically like if you've ever eaten, I don't know, like maybe cotton out of a bag. That's what it tastes like. So I just sit here and watch her eat hers, and I just eat my bowl of fluffy cotton, and then I just put it away because I'm angry.
Now, another way to tell is if you look at the grams. I bet that Halo top is a pretty small amount of grams because there's a lot of air in there.
AJ, I bet you had no idea that we were both ice cream experts, mostly Cole.
It's making me know I'm a novice here.
Yeah, no, for sure. I could take one look at you and realize this guy doesn't know anything about ice cream.
If you're ever wondering, Bluebell is just high quality ice cream. It's just fantastic.
I did write that down.
Good.
I did not realize that Cole is such an ice cream snob.
I really don't eat it that much. It's just now that I know.
Huh.
I know, and
yeah.
it's like you eat the frozen dairy
unknow
dessert. It's like this is like the stuff I grew up eating. Can't even eat that anymore.
Yeah.
No, it's like a waste of
It's
calories.
like peasant ice cream.
Peasant ice cream. So the point is, I don't think I had a true lactose allergy or anything. We just did a little mini elimination diet, and after a few months, I tried milk again, and it was fine.
So you had an allergic to cheap ice cream.
That's what it was.
You
That's what I
needed
was
the real-
allergic
that's
to.
what it
I needed
was.
the real stuff.
You were like, dude, I don't know why you're trying to save a buck here, but I need real ice cream. Mom.
Yeah, but those are all circling back. Those are all ways to confirm or test for a food allergy to know what we need to do.
Obviously, too, if you are going to do some sort of food allergy, this needs to be done in the clinic or hospital setting that have like the appropriate personnel and equipment that, if somebody does have a systemic reaction, you can treat that.
You don't want to take your safety pin at home and dip it in milk and then prick the back of their back. Don't do that.
Yeah, no, that's ill-advised.
That's a bad idea.
Very much so. And then, also check to see if they're taking any sort of, medications that could interact or interfere with the treatment itself of anaphylaxis. So like make sure they're not on chronic beta blockers or something like that. So yes, we want to make sure that we do this very carefully if you do the food challenge.
Yep.
Let's see. What else do you want to go to? Any other challenge? There's a whole bunch of these challenges. We have single blind and double blind and all that stuff.
There's a lot of acronyms.
You really get carried away with that.
It's just if you're worried about whether or not it's truly an allergy, that's when you go down that rabbit hole. But we won't. So yeah, ready for some treatment options.
You want to go to treatment?
Yeah, sure.
All right. Because the other thing too is the actual. What is it? The allergy testing as well.
You can do that. I didn't talk about that.
All right, let me see. I just got out of that screen. The intradermal skin testing, for example. And so the issue with that is the risk of inducing like a systemic reaction with this type of testing tends to be a little bit more than something like same with the skin prick test. But the intradermal testing for food allergies, is still a thing, but it's really advised to be avoided at this point just because of the increased risk of anaphylaxis and whatnot. The other thing would be like what they call a patch test, where you're basically exposing the skin to a specific food allergen for 24 hours, and then kind of evaluating the area to see if there's any sort of erythema or papules that kind of pop up within a day to 3 days afterwards, and this can help with patients who have food allergies. It's associated with eosinophilic esophagitis or enterocolitis, as well as atopic dermatitis. And then there's some studies that are looking at how effective this technique can be in other areas and how it can be utilized elsewhere. And then also looking at like total IgE concentrations as far as from a peripheral serum measurement of eosinophils. That can also, in some cases, give you, it doesn't confirm diagnosis, but can give you more information. There's things like basophil histamine release assays. But, that's, again, an area of more research and whatnot. There's a whole bunch of other ones. Food-specific IgG, IgG subclass antibody concentration testing. There's leukocyte cytotoxic tests, the kinesiology-based testing. There's all kinds of stuff that's on the horizon, if you will, but we just don't have evidence that shows that they're super effective at being able to truly diagnose or not. So, be aware that there's a lot of different things out there. If you're in this space, hopefully you can shed some more light on this as time goes on and more data comes through.
Yeah, because there's actually going to be, new drugs coming out to kind of prevent these things from happening. So as far as treatment, I'm actually going to start with like the more emergent treatment, which is probably a little more intuitive and what people are familiar with, and then we can talk about some of the prevention and other diet-specific treatment measures. But for the most part, what you think of is correct. You would want an Epipen and an emergency plan kind of along with that if you have a patient who has a food allergy, especially if you know that it is severe and anaphylactic. But even if you're not sure and the patient wants reassurance and peace of mind, seems fine for them to carry an Epipen around and just have one. So coming up with an emergency plan is the first step. They actually have some forms online that you can fill out, and if it's a kid, you can turn them into daycares, schools, work, college dorms, whatever, so that they have kind of something on hand to know that you have that, especially if it's definitely severe and life-threatening. It's advised that patients wear some sort of medical identification, like jewelry indicating that they have a food allergy. I mentioned the Epipen to be able to carry that around and have it accessible and have proper training on how to use that. Emergency contact is part of the emergency plan, and having that available. And then anticipatory measures, if 911 needs to be called, and so that the places that they're at, like school or work or daycare, has those things on hand, so they can just have a plan and feel comfortable with it. As far as the Epipen, or the epinephrine injection, comes in multiple brand names. There is a adult dose. There's also a kid dose, and that's weight-based for the actual Epipen brand. It's an auto-injector device that can be injected through clothing as well if you need to. There's other brands. One's called Adrenaclick. There's also AviQ, which is a more, recent one. The big thing with it is that it can talk to you. So I have not used one personally, but I imagine that it's kind of like a defibrillator device that you're going to find at your local, grocery store or something hanging on the wall, that it'll talk to you and hopefully will be generally foolproof so somebody who's not trained can use it appropriately.
Wasn't the AviQ device the same? Wasn't it a similar device that was in that It wasn't Narcan, but it was the naloxone.
The injection one.
What was that thing? I can't remember what it was called now, but it was the one that basically walked you through. It would start with an E, like Evoke, I can't remember.
I'm not sure.
But it basically was like $4,000 for Narcan when you could just...
Right.
So it didn't do super well in the market.
What I've seen AviQ tried to be dispensed, usually it's rejected by insurance and they want Epipen.
I think it's a similar device. I may be making that up, but for some reason I feel like I've seen one. It was the same device, just kind of like recycled.
Right. And the Epipen is generic now. There's generic epinephrine pens. Does that mean it's cheap? No. So there's a big controversy about that a couple years ago, but they remain pretty pricey. They're not as pricey as they were then, but that's a definite frustration when this is literally a life-saving device. But in an emergent situation, there's other drugs that might be used for other general things, but for the most part, the Epipen is obviously standard. There's bronchodilators. You don't want to use that alone, but it can help, open up the airways if you need to. Oxygen, glucagon in severe situations. Then for more mild symptoms, medication-wise, antihistamines, right? This would be the first thing you would think of. A kid having a mild allergic response would get Benadryl or something like that. Also, H2 blockers. Actually saw that a fair amount in practice. I think they would usually use Cimetidine, weirdly. I don't know if that's the best idea. But for allergy type things, I would see Cimetidine a lot. But in general, H2 blockers can be used to kind of mediate a mild allergic response.
And it makes sense too, because if you're thinking about just because something's selective, it doesn't mean it's purely only selective to that. You're going to get a little bit cross reaction there. So if you're having an allergic reaction, you're giving your H1 blockers or your traditional antihistamines to block that side of things, but you might get some H2 activity. So it's almost just kind of like little sprinkles on top to block the other side. A
little sprinkle of Cimetidine.
Yeah.
A little sprinkle of drug interactions.
Right. Don't even get me started on Ranitidine.
Which, have we already talked about that they're branding them?
Yes.
Oh my gosh.
So stupid.
I literally
it's
saw
new formulation.
I saw a commercial of it. It's called
Zantac.
Zantac 360 is what they're calling it.
That's awesome.
Just add the
we
360.
We need to come up with that.
And we can
need to
rip
come
off
up with
Pepsid.
core console acid relief.
360?
Famotidine 20. No, ours is going to be 720.
720.
Ours is going to be like, that? Those
Why
other
not
guys,
1080?
You need so many spins in your treatment algorithm or whatever.
Ridiculous.
Stupid. But yeah, the other thing I just want to mention too about the emergency plan, I don't know if you noticed or mentioned this, Cole, but with the if you're as far as like coming up with an emergency quote unquote plan, if it's not something you just want to draw from scratch, they do have like example plans that you can download at www.foodallergy.org.
Yep.
So making sure if your patient doesn't feel comfortable, if you don't have like those documents to kind of hand out to patients, make sure that they visit that website and get some more information.
Yep.
All right. So we went through all the emergency meds. I guess we'll talk about this new peanut allergen powder.
Yeah, go for it.
So it's kind of the first of its kind on the market, but it was approved in 2020. I can't say that I've personally run into anybody on this at this point, but it's Palforzia, and it's literally just a peanut allergen powder. As if not surprisingly, it has a black box warning associated with it because, believe it or not, it can cause a reaction if you're giving peanut allergen powder to somebody. But it's something that can be used to kind of slowly administer the dose up to get the patient more accustomed to in their system, but it's a very, very slow process over many weeks. Basically, the patient is starting at the 3 milligram dose, which is there's 11 different dosing levels. So they start at 3 milligrams, and you can do that. The first initial dose is going to be under physician supervision to make sure they don't have a reaction. And then each time you go up on the dose, then you want to make sure that you, again, do under supervision. But 3 milligrams for 2 weeks, then it goes to 6 milligrams for 2 weeks, then 12 for 2 weeks, then 20, then 40, then 80, then 120, then 160, 200, 240, 300, each 2 week intervals. And again, each time you go to a new dose, you want to do that higher dose at under the supervision of a clinician and make sure that they do have an issue that you can kind of attack that.
And for reference, I won't go into all the details of the trial that got it approved, but 100 milligrams of this drug is approximately 1/3 of a peanut kernel.
Yeah, it's very small.
1/3 of a peanut kernel. So it's a very small amount. But I guess in some people that can cause, severe allergic reactions.
So, once you get up to the 300 milligram dose, then you're just kind of staying there as far as the maintenance dosing.
And that's one peanut kernel.
Right. You have one peanut kernel worth of powder. Now, what happens because this is daily use, what happens if you miss a dose? The package insert says that if you miss 1 to 2 consecutive days, basically you're just resuming the dose at the same interval, and continue at the same dose level as well. 3 or more consecutive days, that's where things get a little bit murky. So if you look at the package insert, it says, has not been studied, please contact healthcare provider, which is you guys. So the good news is you're going to have to make it up on the fly. And so, it's going to be something that you probably want to go ahead and, if you do resume dosing at the same level, bring them back in and do it under supervision just to be safe.
Or just start back at, if there's no guidance, if it was me and there was no guidance and this was a severe reaction, maybe start back lower. But or if you can supervise them and just watch. Yeah.
I would just say, dude, you know what? Not only are we going to start back at the same, we're going to increase it again and see what happens. Then we'll have data.
And then go home. Here's your kernel and a half. And
the thing is, that was
take 2 and go home.
Now we know what happens. So we're going to know that we need to back that dose down. And that's my contribution to science. I feel real good about it. And then obviously if a patient's not able to tolerate it, we do want to discontinue because we don't want to kind of force it if they can't tolerate it. But if you have any sort of patient who's unwilling to take daily dosing, or if they have issues with like losing control of their asthma symptoms, they have suspected eosinophilic esophagitis, then we probably need to look at getting rid of it. All right. So what else, anything else in particular on that?
That's all I had on that.
And it's approved in children only. Am I correct on that? I think it's up to 17.
Oh, interesting. I didn't know that.
So I think it was efficacy was not shown in participants 18 years of age and older. I need to double check myself so I don't say something stupid, but it does come as a capsule and a sprinkle packet. So pick your poison there. But the sprinkle packet is the 300 milligrams, so that's not obviously used for the dose titration.
Right.
Because I think so much dead airspace. Oh well. As I'm looking for the answer.
Well, while you're looking, which it sounds like you're right. That would make sense. This is most common in kids for sure. But the last thing I have is probably the most important treatment option, which is most commonly used, which is diet, right? So we have the one med that might help with peanut allergies, not all peanut allergies, but that's still pretty niche, right? We don't have things out yet that are going to help with other allergies. So an elimination diet is probably or otherwise known as allergen restriction, is probably going to be the best thing that you can do. So a properly managed, well-balanced elimination diet can resolve symptoms and avoid nutritional deficiencies, right? That's why it's important to do it under supervision. So you want to talk to the family about how to properly read food labels, identify common words that might indicate the presence of an allergen. There are laws on the books, in the U.S. at least, that require major allergens to be listed and identified as ingredients using, quote, plain English. But some of those might be egg, milk, wheat, soy, peanuts, tree nuts, fish, crustacean, and shellfish. All those should be on there. But not all potential allergens are listed and included. Some might be under spices or natural flavors. So yeah, especially if it is severe allergic reaction, you want to make sure that you're being as careful as possible and seeing whether it has that or not. Preparing meals needs to consider avoiding cross contact through shared utensils or other appliances that might come in contact with the allergen. So either just totally keeping it out of the house or wiping those things down. With elimination diets, you want to exclude only the foods that you know are going to provoke an allergic response, which is why that diagnostic food elimination diet is important, so we know exactly what it is and we're not having to eliminate a bunch of stuff to reduce risk for deficiencies and that sort of thing.
One thing too, I need to make sure I add in because I forgot to mention this. So with the part that I was talking about with the dose titration, the up phasing. So before that, because I was talking about when you start at 3 milligrams, I totally didn't even mention the initial, so there's the initial dose escalation phase, which is done in basically a single day. So you're starting with 0.5 milligrams. So that's the very tiny dose, and then you're waiting 20 to 30 minutes basically to kind of see how they respond, if they're doing okay. And this is all done in clinic under supervision. And then you would go up to the 1 milligram, 20, 30 minutes, then 1.5, then 3, then 6. And then after 6, you have to wait 60 minutes to make sure that they don't have any issues and whatnot. And the package insert says that's specifically in patients who are 4 years of age or older up to 17. And then once you've hit that dose, then that's when you're going to the up dosing phase where you're doing the every 2 week all the way up to 300. So I'd make sure I mentioned that before.
Nice.
Stick my foot in my mouth.
The last thing that I think is pretty interesting is there can be cross-reactivity between similar allergens, right? Mm-hmm. So, people wonder which came first, chicken or egg. Eggs and chickens, or I should say eggs and chicken meat that you would eat. It's a gross way to put it, right? Chicken meat. You can have a cross reaction with those. So you have an egg allergy. There's about a 5% chance that you may also be allergic to actual chicken, which to me is like there's a 95% chance that you're not allergic to chicken. Which I'm wondering, here's what I'm wondering. This is presuming that these are chicken eggs that you're eating. What if you have like a snake egg allergy? Or like an ostrich egg allergy, then what does that mean? Are you allergic to snakes? I don't know. There's all cow milk, right? So cow milk can have some cross-reactivity. One with beef. So people who have an allergy to cow milk have about a 10% chance to also be allergic to beef. People who have a cow milk allergy have about a 90% chance to be allergic to goat milk. So bummer, I can't drink any more of that goat milk. Fish, there's greater than 50% allergic chance to any fin fish, that you're just reactive to all types of fin fish, which is a bummer. Peanuts and legumes, soy and other legumes, wheat and grains, and then tree nuts and other nuts, greater than 50% chance that you will have some cross-reactivity. So that's an interesting factoid, but also a warning that if you have this one allergy, you might want to test or avoid other similar things because you could have some cross-reactivity.
And kind of going back to our medication that we were discussing, one thing I do want to mix, I know we said that it comes as the sprinkle capsules and a powder that once you get to that higher dose, but the capsules are not meant to be swallowed. So that's the other thing.
You bust them open.
Exactly. So there's sprinkle capsules because you're actually open. I just want to make sure we also clear that up because that's a good counseling point for people that are involved with dispensing this and whatnot. But you're opening the capsule and or the packet obviously and putting it onto a small amount of something like applesauce, yogurt, pudding, some sort of semi-solid food, and then immediately giving it to the patient. And then also making sure that after you've kind of mixed it up, if it's you're doing the mixing for the child, make sure you wash your hands obviously afterwards because the powder can be left in your hands residually and then you can touch the child. And if they have contact reaction as well, then not good.
Problematic.
So yeah, just want to make sure I mention that too because it's oral can be or a capsule just a lot of times is assumed to be oral. Not too many. I can't think of any other medications that are commonly used that you would open up the capsule every time you take it.
I think there's a Topamax sprinkle. I think there's a Depakote sprinkle cap.
That's true.
And I guess I never...
I guess Spiriva Handyhaler had the capsules that were meant to inhale the powder.
But I guess I never thought about it. But I guess if it says sprinkle cap, it probably is meant to be sprinkled. Because I think there's a Topiramate sprinkle cap as well.
Yeah, I think there is.
Interesting.
So,
for kids, mostly for kids.
Yep.
Those pizza people. I like how this article said to also encourage avoidance of high-risk situations like buffets and picnics.
Yeah.
Did you ever think a buffet or a picnic would be considered high risk for anything except for heart disease?
Have you ever seen? I was going to say, it's high risk for...
no more Golden Corral.
Yeah, no. If you go to Golden Corral, you need to see me after class. 'Cause that is just a bad life choice. There's no way. No offense if you own a Golden Corral franchise, but I went in there one time.
I'm sure we have a lot of people listening who own Golden Corral franchises.
Big Golden Corral fans that listen to this podcast. But yeah. Ugh.
When I was in high school, before every football game, we would all go to Golden Corral.
Carb up.
Just an awful, in hindsight, awful idea.
It's the worst.
There's a really good documentary on Netflix about meatless diets and that sort of thing, and athletes and all that. Mm-hmm. And we were just gunking up our arteries with fats, and it was just a bad idea.
I'll show you all the rebuttals to that documentary.
Okay, whether or not that's good whether or not that's true, either way, we weren't a very good football team, so this might have played a part in that.
No offense to any of our vegetarian or vegan listeners, we love you guys, but That I had a few issues with that thing. I'm glad that there's people that do that diet, but
I definitely will not say that I'm meatless, but I will say it's compelling.
It was interesting. But yeah, so some other stuff that they're kind of have on the horizon. There's definitely studies that are being evaluated right now, looking at different like oral or sublingual immunotherapies, and made specifically for different food allergies. And those are all kind of underway. So hopefully we'll have some new treatment options fairly soon. There's also some studies looking at things like the olizumab, the Xolair, and then using that in conjunction with immunotherapy is also being looked at. And so there's definitely some things on the horizon, but hopefully we'll have some solid things pretty soon. I think there's one on a specific. It's an IgE mediated cow's milk protein allergy treatment. So very specific, CMPA. Cow's milk protein allergy. That's everything's got an acronym.
Everything in here's got an acronym.
But that's being studied at 150, 300, and 500 microgram doses, and it has 198 milk allergic patients in it.
Wow.
It was showed to be statistically significant desensitization to milk in children 2 to 11 years old.
We're going to nip food allergies in the bud.
Someone's got to.
We're going to nip it. Have we done one on celiac? I think we did, right?
That's supposed to be your job, is to keep track of what we've covered. I don't keep track.
I will look, but that would be a good follow up to this. But I think we did it already.
I don't know what we did last episode. So yeah, that's Cole's job for sure. Anything else with this?
That's all I got, man.
AJ, we forget anything?
Nothing. We got it.
Right on. I just want to hear AJ's deep, commanding voice.
Yes.
Wish I sounded cool like that. Get less ridiculed on the comment section.
Just comparing you to Joe Rogan. So who would he be compared to?
Who?
Somebody with a deep, commanding voice. AJ.
I have to think about it.
I don't know.
Dude that plays Darth Vader.
There we go. What's his name?
Which is what's his name? He's great. It'll come. Man, everybody's screaming it. It's like it's that guy from Field of Dreams.
Glover? No, what's his name? What's the heck is his name? Yeah,
he's Field of Dreams, right?
Or is it Sandlot?
No, dude. I think he's in Field of Dreams.
Oh, no. We have to Google this in the middle of the show.
I think he was blind.
James Earl Jones.
There he is.
There we go.
What did I
That's
say?
the fact check of the day.
Thank you, AJ. Okay, AJ, you got a new opportunity to really capitalize on your position over there, and that's Google the nonsense that comes out of our mouth.
Which I'm really upset that we didn't know who played Darth Vader, by the way.
Dude, I know.
We should have known that.
Hayden Christensen's the only person that plays Darth Vader as far as I'm concerned. Oh, that was the nerdiest thing we've ever said in this podcast, in the history of this podcast.
No, we've said some nerdy Marvel stuff. That's okay.
Okay. All right. We'll take it. All right. Anyways, sorry, guys. For those of you who get annoyed by that, we've saved it to the very end to really throw you off. But thank you guys so much for listening. I hope you are still liking the show. Definitely let us know if you have any questions, concerns, comments, any of that good stuff. Send us an email to be in the show notes. You can also reach us on pretty much any of the social media platforms. If you have any ideas for topics or want to be a guest or anything like that, then, for sure let us know. And we'll see if you make the cut. Just kidding. It's not a very rigorous application process. And, you can also reach out to us via text if you want. So you send a text to 415-943-6116. We'll get back to you on any of those platforms as quick as we can. It might not be instant, but we'll do our best. Also, check out our Patreon account if you want more lecture-style lectures, if you will, topic discussions on various disease states. I think we have going on, we're getting close to 100 lectures on Patreon, I think. So thousands of PowerPoint slides. And so I've even had some people reaching out saying they've used it for studying for the BCPS and things like that.
Cool.
So, turns out we're a BCPS study program now, officially. So if you guys want, we guarantee 100% success or your $3 back. So yeah, sure. I feel like that's an easy one to go with. They're not going to chase us down for $3.
It's a no-brainer.
It's a no-brainer. So it's good. It's the right business move. Anyways, thank you guys so much, and we'll try to stay more focused next episode. We'll see you guys next time. Thanks.